Hey, Future Medics, Tina here, your medic mentor, and today we're talking about a medication that's been in EMS for quite some time. It's atropine sulfate. Now, you're going to see this one in both cardiac protocols and toxicology protocols. So let's dive into it. Atropine can be given to patients whose heart rate is too slow to try and return that heart rate to a more sustainable rate. Now, atropine is what we call a parasympatholytic, which means it blocks the parasympathetic system. If you'll remember from your A&P, the autonomic nervous system branches into the sympathetic and the parasympathetic system. That sympathetic is that fight or flight that raises our heart rate, our blood pressure, and lets us run miles to get away from a threat. But then the parasympathetic is the one that returns everything to normal and slows the heart rate and the blood pressure and allows you to start digesting again. So you have your fight or flight and your rest and digest. We're going to focus on the rest and digest. So the patient's heart rate is too low, which means the parasympathetic is probably acting upon it. Okay? So the parasympathetic has acetylcholine as its main chemical mediator. And acetylcholine binds to muscarinic receptors to flip the switch to calm everything down. Atropine will come in and block those muscarinic receptors, not allowing any binding to happen, and so we don't allow the parasympathetic system to work to slow anything down. It's kind of like taking your foot off of the brake of a car. You allow the car to start rolling forward with momentum, and you can even speed it up if you apply gas, so that sympathetic system, but all because you took your foot off of the brake, allowing for that momentum to happen. The standard adult dose is 0.5 milligram to 1 milligram IV or IO every 3 to 5 minutes until you reach a max accumulation of 3 milligrams. Now, onset is immediate. It starts working on the SA node quickly, and it will last about 30 to 60 minutes depending on your patient. But here's the catch with atropine. It does not work for every kind of bradycardia. If your patient has a higher degree AV block, you're probably better off reaching for pacing equipment. But atropine isn't just for slow heart rates. It also plays a vital role in toxicology, specifically with organophosphate poisoning and nerve agent exposure. These toxins flood the body with acetylcholine, which is used in the parasympathetic nervous system. The flooding of acetylcholine causes sludge symptoms, salivation, lacrimation, urination, GI upset, and emesis. By giving atropine, which blocks the parasympathetic system because it's a parasympatholytic, you remember, we can help calm those symptoms down. For this kind of poisoning, the written dose is 2 milligrams IVIO-IM until symptoms improve. Just know you're going to give a lot, and you're just going to keep giving it. You're just going to keep giving it. It says give another one like every 5 minutes. You're going to give a lot of it in this situation. Let's talk side effects. Now, we are giving something that blocks the parasympathetic system. So we're going to think our side effects are going to be more like the sympathetic nervous system. We're going to see increased heart rate, dilated pupils, flushed skin, restlessness, dry mouth. Those are all super normal to see with this. Contraindications are glaucoma, myocardial ischemia, or tachycardia. But if we have a tachycardic patient, they didn't need this. Here's your takeaway. Atropine is safe, reliable, and time-tested. It's been around for a while. It is your go-to for symptomatic bradycardia, and also for toxicology where your patient is just drowning in secretions. Do be aware that it's not for every type of bradycardia though, and if this isn't working, you might have to move to pacing your patient. But that's it. Another med card knocked out. You're doing such a great job. I'll see you for the next one.